a chronic presentation, you can do some prone work. But for the purposes of your OPs and making sure that you demonstrate what's necessary for the condition for the purposes of your mark, we know that supine is best, regardless of the stage. All right. Great, Byron, thank you for joining us. Okay, now after we've done that thorough assessment based off of the doctor's note telling us you have torticollis, we have deduced that you are going to start with the acute stage and then move into the chronic stage. So I'm going to go ahead and wash my hands, but before that, we are going to go ahead and go through the consent for what we're doing today. We are going to be providing treatment to help you with the symptoms related to your torticollis. So treatment today will require me to place my hands around your upper back and shoulders, probably around your neck area, a little bit around the head as well too, and probably around the upper chest as well. So with treatment, hopefully we'll be able to decrease some of your symptoms related to your torticollis, including the pain you have, decrease some of the restrictions once you're in the chronic stage, and just sort of decrease your overall discomfort. But there is a chance we might possibly provoke some discomfort while we are treating you, so please let me know if you experience any discomfort at any point, and we'll modify accordingly. Also, there is a chance you might notice some discomfort for a little while after treatment, a day or so, which is also totally normal. Hopefully though, we'll be able to successfully decrease some of your discomfort. Do you have any questions about what we're going to be doing so far? No. Perfect. I'm going to go wash my hands. Can I get you to please undress yourself in the upper half of the body, having yourself covered, but then laying facing upwards on the table with your head down here. Yep. Do you have any questions for me? Nope. Do I have your permission to continue? Yep. Thank you.
Stop. Pause.
Pause. Alright, so in the acute stage, even if I had more treatment time, I would still just have him turn facing upwards. In the chronic stage, if I had a full treatment available to me, I would start with him face down. But for the purposes of us demonstrating appropriately for today, okay, Byron, I'm just going to go ahead and place a pillow underneath your knees, please. Oh, thank you. Is that okay? Yep. Perfect. Alright, we will be communicating on a pressure scale of 1 to 5, so you can communicate the amount of pressure that you're feeling at any point in time. Would you like me to go through that pay scale with you?
I'm good.
Thank you. Alright, so first and foremost, my hands are quite chilly, so I apologize. Just do this just for a second. I sometimes do this if my hands are too cold. I find like a more lateral portion of my patient to just like introduce my really cold hands, but also it'll slightly warm up my hands. Alright, so first and foremost, we're gonna say we'll go with the same theme, and it's your right side SCM that's affected. So which way is his head tilted?
Right.
Right side.
What is the magic phrase, my friends? Ipsilateral lateral flexion, contralateral rotation. Thank you. All right, so this is the position that our patient is in. Sometimes, if it is quite extreme, they may be kept in a slight element of head flexion as well too, in which case, if you can see that they're in a pained expression, place a pillow. That's real world situations though. For your OP, don't worry about it. Okay, so we know his right side is affected. So right now, I'm just gonna go ahead and see how fascially things are, and you're actually more tight on your right side, so that's good. All right, so normally I work on his unaffected side first, so I'd be working into the upper back and shoulders. And nice big breath in. And good. And just doing your general techniques to help encourage your patient to just relax. Drop your chest. Not force it, just gravity. There you go. Good job. To the affected side, again, do just a little bit of work into the back and shoulders, giving him a chance to focus on relaxing. Now, we know that he may have a hard time doing deep breathing, so just telling him to just continue breathing. Go ahead to the gentle breath. Good. And then once you've had a chance to go ahead and do some work around the compensatory structures, of course, I'd spend more than 30 seconds treating those. And then you could absolutely go into the unaffected side working directly. So we've already talked about how we can go and work directly on the muscle belly of the unaffected side, right? So we can actually challenge and go right into that unaffected side. So once we've done some work into this unaffected side, this is when we're going to start honing in on that affected side. Now, I'm still not going to be doing any direct work. We're still in the acute stage, so muscle belly work, just avoid it. If anything, you want to focus on the attachments. Now, before I get right into the attachments, I'm going to continue with even more fascial work. So again, we're not going to go right onto the attachments of the SCM. We're going to go inferior to the clavicle onto the superior portion of the pec. Now we can do some direct, indirect fascial shearing here. Where are we on the pain scale? 2. Good. And you can actually see how when I'm applying the fascial work here onto the upper chest, it's going right up into his neck. Right? Nice breath in. And out. Good. So how do we apply a GTO release to the SCM? What is a GTO release?
We're just going to attachment.
You got it. It's essentially C-bowing the attachments, right? So with the SCM, I'm going to get you to just go ahead and lift your head towards the right there, just so we can go ahead and back down. So that's his SCM right there. It's not in spasm, so it's not super prominent, because he's nice and relaxed, which is great. But actually, I will get you to do like a semi, there we go, like so. So now we can see his SCM. Okay, when it comes to GTO release, because the attachment is right here, there's a few ways that you are able to bow it. Let's talk about the logic in each. So sometimes people might be inclined to actually go in and bow this way. Problem with that is there's a lot of sensitive structures in the front of the neck, including the windpipe. So when you press downwards like that, you might actually make it uncomfortable for your patient to breathe or even swallow. So I don't suggest that you C-bow inwards, okay? The other two alternatives that I suggest is either bowing medially into that attachment or bowing laterally into that attachment, right? And again, it's always checking in with your patient's tolerance level. Where are we at on that pain scale there, Byron? Take a nice breath in and out. So keeping in mind that he doesn't have this condition, and he says it's a 3. So that tells you just how gentle you are going to have to be with individuals who are currently experiencing this condition. All right, nice big breath in and out. You could go back and forth between the medial aspect, the lateral aspect, keeping in mind you're trying to stay away from that muscle belly. After you've done some work into the attachment, you can go back into some gentle fascial work. Just slowly let that go. Good job. Good, and then the same can be done at the attachments at the mastoid as well too. Now, depending on your patient, you might find that it's easier to bow on the anterior aspect. I don't like the anterior aspect. Personally, I like the posterior aspect. Do you see how broad that attachment point is? Super broad, right? So you're gonna have to actually get tucked in behind. Let go. Good. Where are we on that pain scale?
2.
Nice breath in and out. Okay, so actually what I should have done before doing that GTO release, it probably would have been wise for me to utilize the agonist contract stretching first. Doing the indirect stuff and then getting him to start gently trying to challenge that SCM may or may not be more tolerable than going straight into the GTO release. Yeah?
Would light stripping be contraindicated?
Yes. In the acute stage, you want to stay away from that muscle belly.
Oh, like muscle strip the tendons.
So muscle stripping is targeting specifically the muscle belly. Yeah, when you're doing muscle stripping, it should be along the course of the muscle fibers. So you're starting on one end to the other or segmentally throughout, but either way you are expected to pass through the muscle belly for muscle stripping. So you could do, if you're thinking about the attachments, frictions would be technically stripping at the attachments, but I would not do frictions in the acute stage at this point. So when in doubt, just tell yourself acute, minimal direct treatment. If anything, you're focused mostly on the compensatory things, more the indirect stuff, and maybe a little bit at the attachments, but your primary goal is to just get your patient to relax and address the compensations. Okay, the few specific techniques I would like to see for the OP is apply GTO release to the attachments, as well as your agonist contract stretching. Okay, so if he is ipsilaterally flexed, oh, that's why we took him out of the lateral flexion. Are you okay like this? Yeah. Cool. So ipsilateral lateral flexion with the contralateral rotation is what's actually causing the SCM to be more prominent on this. So to agonist contract stretch this right SCM, which way do we want him to turn his head?
Contralateral.
And ipsilateral rotation for agonist contract stretching. So just to not get confused with our lovely phrase that we're supposed to remember, just tell them to turn their head towards the side that hurts. All right, as best they can. So at first, no resistance. Okay, Byron, I'm gonna get you to go ahead, try and turn your head towards my hand. And somebody in the acute stage will probably not be able to get that much range. But that's the goal, is by getting him to try and turn his head, it is passively stretching that SCM to allow his opposite SCM to contract, right? So it's that reciprocal inhibition that we're trying to utilize. Okay, once he is a little bit more comfortable, let's say like early subacute and whatnot, we can actually apply a gentle resistance. Okay, so Byron, when I say so, I'm gonna get you to try and turn your head to look in this direction, but I'm gonna have my hand on the side of your head applying a gentle resistance to resist you. Okay, we're not gonna get you to move into that direction, but I will get you to just attempt to meet my resistance. Okay, ready? And go ahead for 5, 4, 3, 2, 1, relax. And then you could get him to try and turn his head a little bit. Good. And are we okay here? Good, nice breath in. And just relax here. Good, and then I'll get you to do that again. Gentle try and look for 5, 4, 3, 2, 1. Let go, good. Breath in and relax. Good, and then try and turn your head to look this way a little more. Good. And then, so we wouldn't want to actively pull him into that stretch, right? Back this way. So that is in the acute stage of things. Things that we want to see specifically, agonist contract stretching, which is not actually stretching, right? It's not an actual stretch. Agonist contract stretching, GTO release, and then focusing primarily on the compensations and encouraging what breathing you can. Okay, makes sense for the acute stage? Okay. For the chronic stage of healing. So by this point, he will have more range, but he will probably still be in a slightly contracted position. But he will be able to move his head a little bit more. Here, still starting with the compensatory structures, still gonna work on his upper back and shoulders, still gonna work indirectly into the fascial structures, but now we can start doing gentle work directly to the area. So from here, you might wanna use a little bit of lotion and actually start with your gentle Swedish in this area. Because even though he can now tolerate direct work in the area, that still doesn't mean that we're just gonna go right into it, right? We still need to be gentle. It is still an issue. So from here, gentle stripping. I'm not actually applying a whole lot of stripping because he doesn't actually need it in the area. So if you find an area that is nice and taut, you can actually stop at the attachment and we can apply gentle GTO release anyway. So I'm gently just gonna bow that, relax your jaw. Good, Byron, where are we on that pain scale? 2, perfect, nice breath in. And relax. Right now I'm just gently C-bowing the attachment here. Relax your jaw, let that fade. Very good. Good, and then once I feel like that's released a little bit, I'm gonna actually come up and bow in the opposite direction, just cause I wanna get all parts of the attachment. 5, 4, 3, 2, 1, relax, good. And then if you really wanna be crafty, only within your patient's tolerance, we'll do this at the lower attachments here. When I'm gently C-bowing into the attachment here, where are we on the pain scale? Okay, I'm gonna back off. Where are we? 3, okay, are we able to tolerate here? Perfect. All right, so Byron, I'm gonna get you to very gently, very slowly try and turn your head towards the right for me. Good, and hold for 5, 4, 3, 2, 1, relax, very good. And now I'm gonna get you to go ahead and try and turn your head towards here as best you can, good, and relax there, good. And then I'm gonna try and C-bow into the attachment again. Where are we on the pain scale? 3, okay, I'm gonna back off a little bit. How are we here?
2.
Good. And we're okay here? Good, okay, nice and gentle. I'll get you to try and turn your head again. Hold, 5, 4, 3, 2, 1, relax, good. So you'll notice I'm actually combining techniques now, right? I'm getting him to do the agonist contract stretching, but I'm still challenging the attachment points of the SCM. If you're gonna start combining techniques like that, I suggest don't be grappling onto that muscle belly while you do that. It's gonna be a little uncomfortable. If anything, attachment work only with combining the techniques, just to make sure your patient doesn't feel too uncomfortable. Okay, so for chronic stage, things to focus on, we still wanna see some agonist contract stretching. They'll be able to go a little bit further. We still wanna see GTO release, and we wanna see you start to do direct work into the muscle belly, but gently, okay? But other than that, think general neck treatment with a focus on that SCM. All right, is there any questions about how to address this? Yeah.
So not much of ipsilateral flexion, just to
You can start to recruit that, but it's a lot easier to focus on one direction at a time. So once you've done the rotational components a few times, you can actually say, okay, so now this time, now that we finally got him a little bit closer to center, now instead of turning your head to face this way, when I say so, I'm gonna get you to try and actually bend your head to bring this ear towards the shoulder. So then you'll just change it, focusing more on lateral flexion instead of rotation. So very good question. Do focus on both a little bit. The rotational one is just the easiest one I find for students to be able to see the difference on. Yeah, good question, but do recruit both. Yeah, good one. Any other questions?
What if they start having a cramp in the middle of the session?
Then stop touching it, back right off, and go back to just trying to decrease their SMS firing, and then reestablish consent with your patient. Be like, okay, so I know that was a little bit intense. Are you comfortable with us still continuing with treatment in the area, or would you like us to alter treatment altogether or just stop? Right? So reestablish consent and barriers with your patient and make sure that they're still comfortable with continuing. Yeah. Good news is during the OP, that's not gonna happen. But in real world situations, or if say you got this on the board exam and your examiner on the table said that, then back off, let them know that we'll give them a second to recoup, and then give them their options. If they're comfortable with it, we can give them a couple seconds, focus elsewhere, and then come back to work on the area. Or if it's too much, then we'll just work compensatory structures around the area to not provoke any more discomfort, or if they'd like to just terminate treatment entirely. During board exam, they probably are not going to terminate your treatment. They are probably going to say, no, keep going. But they're probably going to do that with the purpose of seeing how you'll respond, whether it just be like, just suck it up, and just go into it, which would be like, don't do that, right? Reestablish the boundaries with your patient. Yeah, good question, very good question.
What if they also have like a headache that just lasts throughout the treatment?
Oh, lovely, then that's when you would actually target the compensatory structures related to headache stuff, which is like the occiput, the subocciput, occipitals into the posterior aspect of the neck, and then you can focus on more headache related treatment as well too. But we do know that sometimes the trigger points in the SCM can contribute to the feeling of headaches as well too. So that's why our primary focus is going to be into the SCM, but for say board exam or in clinical synthesis, if that's like a secondary thing that they're complaining of, then you're going to be catered more compensatory with headache component with SCM work. Right? So it's just, if there's additional components such as headache, such as jaw discomfort, then we will just continue adding on to what we're going to be focusing on for treatment. Keeping in mind our primary focus is the torticollis, but they just so happen to have headaches, jaw discomfort as well. Make sense? Yeah, good question. Any other questions before we do our trades? Yeah.
I'm thinking about principle of treatment. So the stretch and then you kind of like activate the muscle is not like aggressive to me. So it's like before using like motion, can we apply the like this kind of technique and then we do the like exfoliation and muscle stripping?
So you could. The only problem with that, I wouldn't even call it a problem, is the idea that when you start with the Swedish massage, that's to help promote the relax, let it go, because if they're dealing with pain, they're probably going to be really tightened up. So even if you try and activate the muscle, they're not going to get very far, right? So that's why doing some Swedish work into the area to encourage them to relax will make it that much easier for them to accomplish that motion. And you'll notice that when I was getting him to do that activate, he activated for a couple seconds, then I gave him a second to actually breathe and relax into it. So as much as activating the muscle to perform the technique is important, so is making sure they're able to relax after
First
the technique.
and then
Yeah.
after? Or
Both.
Both?
Yeah, exactly. Good question. Yeah. Because that's a question that you're going to be battling with for a while. Is like, at what point can I use lotion?
Yeah.
Essentially, right?
Yeah.
Yeah. So that'll be a self journey of yours throughout your career.
Okay.
Yeah. Good question though. Any other questions?
You mentioned you didn't use any.
Correct. You could. You absolutely could.
Like, didn't compensate.
Yeah. Exactly. Yeah. Any
What were you
areas.
doing any bowing or-
Correct. Any of the bowing, you want to have like a little bit of a grip to be able to maintain your spot.
Special case.
Yeah, exactly. Worst case scenario, may I please borrow? You could also just apply the linen as well too,
Oh, okay.
right? You can actually use that as a little bit of grip. Good question. Any other questions? wouldn't say so. No, because the SCM doesn't attach directly to the ribs. Keep in mind, depending on which direction and which ribs you're targeting, it could be tender for the patient because it is in the area of their attachment point. So just being mindful about the actual contact you're making because of how close it is to the affected tissue, I would say is your biggest caution. Yeah, but joint mode should be applicable. Yeah, we're gonna be talking more about assessment of the ribs and into the rib cage with breathing and everything as well too when we start dealing with T-spine. Yeah, good question. All right, folks, and now it's time for practice. What time is it?